all the people at Teams as well. I just changed my picture here. It was a winter picture since the end seminar, but I thought this picture was a little bit more right in on today, so I took this picture. So I will. My agenda is that I do an introduction, and then I will present the aim and research questions, and then the research methodology, and then the conclusions and implications. So I'm a researcher and a consultant in healthcare management. It's I'm really want to explore this healthcare management area of both practical and theoretical. My thesis is about COVID-19, and it ended the 4th of May 2023, and then it was 765 million confirmed cases and 6.9 million deaths at that point when it was closed. Several more people have died afterwards, but it was at that point. It was a crisis with an unpredictable and fluctuating demand. It was changing in waves during the whole pandemic. It was a need of surge capacity, especially for masks, and intensive care. That's the most need of surge capacity. But of course, there were other needs as well. I have gone from a price management perspective, where they talk about 4 S's, the staff, space, and system. And I have developed that for the changes between an accident and a pandemic. The aim has been to analyze and comprehend the lessons learned at Swedish hospitals in implementing surge capacity during the COVID-19 pandemic to enhance preparedness for future pandemics. So from that aim, I've developed research questions, and these are the 5 research questions. And it's about both staff, but also a lot about the system and how the system is orchestrated during the pandemic. So the research methodology, the starting point was, of course, the aim. And then I did a quality research, a double case study with interviews. Of course, it's hard to be at the hospital at this point because they were closed. So it was interviews by teams. And from that, I did an inductive analysis and answered the research question 1. And I did then a quantitative research and as a survey, and did an explorative analysis from that point, from that survey. And then the result from the interviews, when we did the interviews, it was quite broad and they talked quite freely. And we had the items we wanted to have in our manuscript. So we could also use these interviews for deductive analysis onto the framework of learning, and also onto the framework of dynamic capabilities, both very important during this pandemic. And all this analysis and research gave us quite a deep understanding of the research and a contribution to the aim. So these research questions, they are directly connected to the papers I've written. And now you see all are green because yesterday evening at 5 o'clock, the last one was accepted. So that was really just in time, wasn't it? So now all these 5 papers are accepted. The time scale during my research has been the pandemic, of course, but we had a starting point after or in the middle of wave 2, and then the interviews were during wave 3, and after that the survey went out, and I wrote the papers. So this is where the intensive care, a person's being at the intensive care you find in the lower part of the picture. And I also wrote out the vaccination, because that was, of course, very important during the pandemic when people started to be vaccinated. So the framework of a forest by Branas et al. Look like this. You have the system that needs to be orchestrated to be able to deliver in stuff and space. So he was one that put this together. So these papers are written. I just wanted also to show the contributions to these 4 S's. And as you can see, even if I on paper 1 mostly looked at staff, it was also contribution to other S's, so to say. So every S is working together, and we could see, or I could see during the research, that the system and staff was the ones that was more connected or more needed to rely on the others. So that's why they are a little bit more black. So when I then started to have look more at theories and also a little bit on the interviews, finding out what could be interesting to look at in the research. I understood quite early that the pandemic and the major accident is very different from each other. And I could see some interesting items that are different. The length are different. The major accident is short. The pandemic is long. The adaptability needs to be more adaptive in this waving demand. And it could be more rigid in the major accident, because then you need to have quite a lot on one point, but then you don't need it anymore. And the familiarity is different as well. The major accident, the patients are known. They have been injured through physical violence. But on the pandemic, I've heard doctors saying that, oh, I'm a specialist and I have been that for several years. But I felt like a new beginner in this pandemic. So that was quite a big difference between a major accident and the pandemic. So after the research, I developed the framework even more. One thing that was very interesting to look at, and it's also made a lot of changes between an accident and a pandemic, is where the information went from. Because during a major accident, you have a rescue leader that calls the head of the region saying, now we have 100 patients here, where shall we send them? And the region management, they say, send 10 there, 10 there, 10 there. But in the pandemic, they didn't have a clue, because the doctors had their network and got information from the network. So they knew quite early that this will be happening from the colleagues, international colleagues. And then the patients arrived at the hospital. The region didn't know. But the doctors at the emergency, they saw the patients. And they also felt how many patients do we have now, how many is intensive care. So this information flow really are important due to that the contingency plan is more onto this more hierarchic way of treating and managing the major accidents. The adaptivity was, as I said before, adaptive at the pandemic, rigid at the major accident. And the hierarchy, it needs to be more distributed, because the people that need to work long in this organization and treat a lot of patients for years, then they need to have management over their own situation. But of course, when it's a major accident and you know you should only be there in a few days, you could be ordered. You could just stand there and do surgery. That's okay. And the trust, it's very important with trust in the organization. And for pandemic is a trust for learning, and the major accidents is trust for decisions. As I said, it's okay with the decisions. You need to trust that somebody else does the other patients. I have the responsibility for these two. So there you trust the decisions others have made. But in the pandemic, you need to trust that you can learn how to treat the patient, because I didn't know in the beginning. So it's a difference about for different accidents and prices. This is only, I have put some of these prices into this diagram, where I have thought about how long duration or short duration, and if it's none or unknown. And I see that I think a pandemic will be in the upper right position, and a big accident will be in the lower left. And to have more dynamic contingency plan for the upper right. And maybe you need to have different for all of these. I don't know, that I haven't looked at. I have also found out that this learning is very important. And as I also teach lean in my other profession, I usually do use this plan, do, study, act from Deming. But I also have read a lot from Boyne and learning, and then I have added these two together. This hadn't been in a paper yet. Maybe it will be in the future. But I found this discussion very interesting, because if you need to plan something, plan an experiment, you need to sense. Sensing is from the learning. And that's very important, to sense the right thing, because otherwise you will do the wrong experiment, of course. And then you have to do these meaningful decisions when you are planning the experiment. And then you do the experiment and you study the experiment. And then again, you need to sense what did happen during the experiment. What was good, what was bad, what will we do? And then if it's good, then you can act and you can put it into the routines. And then you also have the organization's memory built from that. But in this, you have also power games that can destroy it all. And you have the positive storytelling. If you get the first person that goes to the intensive care, for example, when they're not used to be there, and they come back and say, oh, it was okay. It was okay to go there. Then other people will go there as well. Because the biggest problem was for the staff to move around the hospital, because they were scared, both because of the infection, of course, but also because they didn't have the knowledge. It was very important to get the first persons to give a positive story for others. So that's something I think is important to look at. So now I will only in points tell you the theoretical implications I have made for this. I had done a framework for constructing staff search capacity. It's about the epidemiologists, I think it calls. They say how many patients it will be, because they look at the infection and how that will proceed. But who is developed that to how much capacity you need? Just from my other experience, I had a hospital that said, but we said yes to 2 patients from the ambulance coming into our 2 more patients from another area. And with our inpatient care. Why? I said, how long will they lay at the hospital? 4.5 days. Yes, then it will be 9 beds every day that will be occupied with these 2 patients per day. You understand? It's very important to understand the capacity need from the amount of patients. So that's about the paper 1 and 2 is about this. Develop framework for crisis management in pandemics. And that is also for all papers and an integrated chapter. And that is also what I presented here. Causality planning strategy. employing a stepwise planning approach towards a scenario. That I have observed that they were doing, that they were always planning the next step. And that was good, because then all the employees around could see what next step is. And it could be very clear that now we're going to the next step. So then everything that they have found out for the next step is started. An innovative method of planning hourly demand of staff in uncertain environments. It's for paper 3. And that was very interesting in this the service department, because they went out, built trust with the managers near the floor, and they said, we need so many masks per hour. That of course changed, caused by how many patients they had. But this trustful discussion made it possible for them to deliver fast when it came more masks into the hospital. So that was very interesting to see how they really worked. They started to work there were 2 people. One started to work 12 hours a day, and the other started to work 12 hours a night. So they went out and discussed all the time. Analyze organization adaptability by learning and dynamic capabilities. I think that's very interesting to do this deductive analysis onto these, because then you could say something about the organizations. There was very big differences, especially when I looked at dynamic capabilities between the cases, and you could really see it when we analyzed it. So this is very interesting with the managerial implications as well, of course, for this quite practical research. And I have put it into 4 stages, or 3 stages, I must say. Preparedness, what shall we do before next pandemic? Early stages, what is important to start with when next pandemic is started? Because in the beginning, it's much more unknown, much more things that happens. And then you need, when it's prolonged, you need to have the staff and space, and you have to have the system. What is the more long-term implications? So the preparedness. You need to have a contingency stock. We didn't have it all in Sweden. And very interesting, it was started contingency production. What do I mean with that? For example, Absolute started to do hand sanitizers, I think it's called. So that, of course, if you could prepare with this contingency production, then you might not have to have so much contingency stock, but you maybe need to have more raw material. So here I think that logistic stock specialists really should dig into this. And I think it's not happening. I'm sorry. Decrease the normal occupancy rate, because in the beginning, if you have 100% occupancy rate at the inpatient, you don't have any beds at all. But you have 90%, then you have 10% of beds in the beginning. So that is very important, especially in the beginning. Staff agreements to facilitate the mobilization. They didn't have any agreements. They did it day after day, really. How much more money can you get if you go into intensive care? That is what should be in place. Beforehand pandemic placements or staff with flexibility and appropriate knowledge. Could you have knowledge beforehand? It's very good. Standardized care procedures and proactive agreements for cooperation between organizations like private healthcare and providers. That is something that needs to be in place before next pandemic. In the early stages, you need really to look, to listen, and to sense the information around the world. You maybe should be able to sense the Chinese information better than you did this time, because we started up when it came to Italy, not when we heard about it in China. Rapid identification of units affected by the pandemic, because if some units are affected and some units will have decreased demand, then you need to know where to move them, who to move where. And if you do that fast, then you have time for education as well. Decline the number of normal emergency patients and the elective surgeries, of course, and that will be natural as well. It will happen. And keep an unbalanced excess of capacity during the uncertain increase in the first wave, provided you don't know anything about it. You don't know where it will be stopped. So try to have excess all the time. And then I have the staff and space. Explore shift and of necessary stuff when treatment protocols are changed. Because sometimes they said, oh, this pharmaceutical will be the best treatment. And then 2 weeks after, this will be the best treatment. So then, of course, the stuff will change what stuff is needed. And like the analysis method was not enough in the beginning, but when they started, they didn't have these pins that could take the analysis. So that, of course, was interesting as well. Use the conceptual framework to enhance the accuracy of staffing prediction, the one I've written about in paper 1. Development of the mobility of the staff. It needs to be thought about, because that was a hard thing, and you need to think about it very early. Early decisions regarding staff and task allocation, and provide individual education. The normal work environment of the professionals should be prioritized when expanding space. These external intensive care didn't work. It's better to really look where to expand in the normal hospital, because you don't have more people because you open something external, and you will dilute the knowledge even more if you need to go out. And system, the last picture. The continuous plan should contain a plan to make a plan, continuously improvements on that plan. Increase the frequency of meetings that everybody did, and nearly 2-3 times a day. Management groups adapt according to the evolving situation. You need to take in the normal manager group the new knowledge you need. Explore information flow. Where do the information come from? Who will have the first information? And let them really share this information with others. This causality planning, I think that was very good. It gave the same goals for the organization, and gave a decision space for the people that did the plans. Explore lag time before the capacity is freed. That's something I saw as well, that when the emergency said, oh no, we don't have any COVID patients anymore, and the surgeons said, oh, then we'll need to start the surgery, and the intensive care said, no, we have 2 weeks more with patients. So that was a lag time of 2 weeks, approximately. That will of course be in another pandemic, but it's important to see if there is these lag times. Regional management optimal position is as a service partner. When they don't have the first information, they need just to rely on what they are asked for and deliver that, really. Trust storytelling and power games need to be observed and explored. I think that was something I have been thinking about more in the end of my research, and I think it's very important. And I think that's maybe important in our daily life as well. Manager with trust and suitable personality traits can manage and implement decisions in the organization. I think that's important also, that when you have trust, you can do something. If you have built trust, you can do something. But if you're not having any trust in the organization, there's no use that try to do a decision. So try to find the people that have the trust in the organization. Those can be doing something in a crisis. So that's what I wanted to tell you about this. Thanks for listening, and I look forward to the discussion. Thank you very much.
Very much, Ritvas, for a really interesting presentation. And I welcome the opponent, Professor Bonnie, and we look forward for your discussion.